Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're continuing with our new series entitled The QME's Clinical Rounds. And in today's session, we're in session number 2. And in this series, we're discussing common clinical conditions that you're going to encounter as a qualified medical evaluator. And it's fascinating because our examinees in the workers' compensation system are a lot like patients in our clinical practice in that they have issues, they have pre-existing conditions, they have comorbidities, they have a prior medical history which impacts the current claim for industrial injury, and these are all factors that you need to take into consideration when it comes time to provide your medical decision-making opinions and conclusions in the body of your QME report. So we're discussing conditions that are commonly encountered in your evaluations as a qualified medical evaluator, and we're discussing some of how to handle these particular conditions when you encounter them as your handling relates to your causation determination, your permanent impairment determinations, and your apportionment arguments, and even your return to work decision making regarding your particular examinee. And in today's discussion, I want to talk to you about a common spinal condition that you will encounter in your examinees who are reporting ongoing back pain and activity limitations due to back pain, even despite extended periods of total temporary disability, even despite extended periods of conservative and even invasive care. This is a condition, and today we're going to talk about Schmorl's nodes. This is a condition that is a known painful condition of the spine that, for the most part, can become stubbornly recalcitrant to conservative treatment measures. And so by the time you meet face-to-face with your examinee, this examinee is going to continue to report back pain symptoms and activity limitations, and will report to you that all conservative treatment measures have been exhausted and have failed to return the examinee to a pre-injury condition. And I share this condition with you today because you are going to encounter examinees who have this condition. And as we're going to see, there's two basic varieties of Schmorl's nodes. There are Schmorl's nodes that are asymptomatic, and there are Schmorl's nodes that are symptomatic. And whether or not this Schmorl's node is asymptomatic or symptomatic, the mere presence of a Schmorl's node is going to impact your medical decision making, because the Schmorl's node is a pre-existing condition that suggests a prior history of injury to the spine. So with that as our introduction, let's begin today's discussion about Schmorl's nodes. And Schmorl's nodes were first described in 1927 by pathologist Christian George Schmorl. And a Schmorl's node is a herniation of the nucleus pulposus through the cartilaginous and bony end plate into the body of the adjacent vertebra. So imagine the anatomy of a vertebra. The superior and inferior end plates of the vertebra are covered with a thin layer of hyaline cartilage. So that's what's referred to as the cartilaginous end plate. That's hyaline articular cartilage. And then is covered with the fibrocartilaginous intervertebral disc. So there's a progression of bony vertebra, hyaline cartilage, and then fibrocartilaginous intervertebral disc, and the nucleus pulposus of the fibrocartilaginous intervertebral disc herniates through the hyaline cartilage and then herniates through the bony superior or inferior end plate of the vertebra into the body of the vertebra. Now this is interesting because we're well familiar with intervertebral discs herniating horizontally into the spinal canal or into the neuroforamen. So those are horizontal herniations. With a Schmorl's node, we have a vertical, either superior or inferior herniation of the intervertebral disc. So fascinating Nucleus pulposus can go in multiple directions, and whereas a horizontal herniation of the intervertebral disc does not confer or require fracture of the vertebra, a superior herniation or inferior herniation in the formation of a Schmorl's node requires actual fracture of the vertebral end plate. So that might give you some hint as to the types of impairment ratings that may apply to your particular examinee. They may apply for an impairment rating due to fracture of the vertebra. So referencing a study in today's discussion, referencing the European Spine Journal, an article entitled Schmorl's Nodes from this 2012 study, they tell us that Schmorl's nodes are common findings on imaging, and you'll probably agree with this. And although most Schmorl's nodes are asymptomatic, some have been shown to become painful lesions, and I'm going to share with you a couple of findings that will help you distinguish between asymptomatic and symptomatic Schmorl's nodes. Okay? Now, with regards to the causation or the formation or the development of Schmorl's nodes, several theories regarding the pathogenesis of Schmorl's nodes have been proposed, and an axial load model appears to have the greatest supporting evidence, and we're going to talk about the axial load model. And symptomatic Schmorl's nodes, differentiating symptomatic from asymptomatic Schmorl's nodes, symptomatic Schmorl's nodes are thought to be due to the inflammatory response solicited by the herniation of the nucleus pulposus into the well-vascularized vertebral body. So if we think about the anatomy of the body of the vertebra, the superior and inferior end plates of the vertebra are cortical cancellous bone, and then below the cortical or cancellous bone is trabecular bone. And the trabecular bone is hematopoietic tissue. There's a lot of red blood cell formation taking place within the body of the intervertebral vertebra. So the body of the vertebra is well vascularized, and when these foreign material from the nucleus pulposus comes in contact with this well vascularized hematopoietic tissue within the body of the vertebra, this can elicit or stimulate an inflammatory response. An inflammatory response has been shown by biopsy through the presence of inflammatory cells in and around the area of a Schmorl's node. So symptomatic Schmorl's nodes are characterized by an inflammatory reaction, whereas asymptomatic Schmorl's nodes have no inflammation associated with them. Okay, so let's talk about some of the causes of Schmorl's nodes. And as we go through some of these causes of Schmorl's nodes, think about which of these causes could be operative in your particular examinee. So I want you to imagine that you have an examinee in front of you face to face in the qualified medical evaluation, and you're well aware, either through the medical record or through diagnostic studies that you may have obtained, you're well aware that the examinee has Schmorl's nodes present on diagnostic imaging. The next question that crosses your mind is, wonder what the cause of these Schmorl's nodes are or is. And so let's talk about some of the lesser common and the more common causes of Schmorl's nodes. Well, some theories propose that Schmorl's nodes are the result of disc degeneration, where disc degeneration leads to degenerative weakening of the vertebral end plate, which is less resistant, therefore, to axial forces, allowing superior or inferior herniation of the nucleus pulposus through the weakened vertebral end plate. And some may say that it's weakening of the vertebral end plate which leads to disc degeneration. In other words, we have a chicken and the egg type of situation here, because there's a lot of flux and transfer of nutrition across the vertebral end plate into the fibrocartilaginous disc and vice versa through the process of inhibition. So there's two-way traffic and diffusion of nutrients through this transitional zone. And weakening of one or the other certainly results in further decay and weakening of the adjacent structure. So in any event, according to this particular study, it tells us that disc degeneration precedes weakening of the vertebral end plate, and then because of the degenerative disc, this segment of the spine becomes less resistant to axial forces due to regression of the nucleus pulposus, and then that additional load, which would otherwise be assumed by the nucleus pulposus, then gets transferred to the vertebral end plate, and the vertebral end plate suffers collapse or fracture in the formation of a Schmorl's node. So that's one particular theory. Another theory has to do with defects of formation in the embryo. Remember, the vertebrae are formed from the sclerotome, where half of the vertebrae and the inferior half of the vertebrae from one somite and the superior half of a vertebrae from another somite come together and surround the nodal cord, and then the nodal cord regresses and leaves a remnant as the nucleus pulposus. So any defects in this developmental process can cause a deformity around the end plate of the vertebrae and even within the intervertebral disc itself. So this theory tells us that Schmorl's nodes form due to a developmental insult, which results in a gap in the developing vertebrae, a gap in the vertebrae around the area where the vertebrae surrounds the nodal cord. This leaves an indentation in the bone into which disc material can herniate due to either abnormal regression of the nodal cord, due to incidental ossification gaps in the centrum of the vertebrae, due to vascular channels, or even due to Sherman's disease. And remember, Sherman's disease is a genetic disorder that results in a developmental deformity of the vertebrae, where the vertebrae become wedge-shaped anteriorly, thinner anteriorly, thicker posteriorly, and this can lead also to a weakening of the vertebral end plates and lead to the development of Schmorl's nodes. Other causes of Schmorl's nodes include pathologic processes. Any pathology that weakens the spine, that weakens the intervertebral disc, or that weakens the vertebral body can allow Schmorl's nodes to form due to herniation of the nucleus pulposus through the weakened vertebral body. So conditions such as osteomalacia, hyperparathyroidism, Paget's disease, infection, neoplasms, and osteoporosis, any of these bone weakening conditions can create a situation where the vertebra is less resistant to axial forces and can fracture when axial forces overwhelm the weight-bearing capacity of those vertebral end plates. Blood dyscrasias such as sickle cell anemia, spherocytosis, thalassemia. These conditions, because the vertebral body is actively hemopoietic tissue, red blood cells, white blood cells, platelets, these are all formed within the interior of the vertebral body. Any disorder of the blood-forming hematopoietic system or hematopoietic process can weaken the interior of the vertebral body, can thin the trabeculae, can reduce the overall number of trabeculae within the interior of the vertebral body and weaken the vertebral body, leading to stress fractures, vertebral collapse, and death of the bone marrow. It's the bone marrow, which is the hematopoietic tissue. Okay? One metabolic disorder known as Gaucher's disease has been associated with Schmorl's nodes because Gaucher's disease, which is an enzyme deficiency disease, leads to easily fractured bones. And to test for Gaucher's disease requires genetic testing because this is a genetically mediated enzyme deficiency disorder. Similarly, osteogenesis imperfecta, the imperfect development of bone, is also a genetic disorder. It's an X-linked recessive disorder, meaning it's carried on the X chromosome. So it's a recessive trait. So males who have only one X chromosome can be carriers, and when they carry the dominant form of the gene, they express this imperfect development of the bones of the body. Females, however, have two X chromosomes, and so a female can have normal development of the skeleton when only one of the X chromosomes carries this recessive gene that creates mutation in the developing bone. So all of these conditions are associated with Schmorl's nodes, and Schmorl's nodes development at any age. Another theory involved or circulating around the concept of Schmorl's nodes has to do with autoimmune involvement, and autoimmune involvement is not suspected as a cause of Schmorl's node in the first place, but may be responsible for the conversion of asymptomatic Schmorl's nodes into symptomatic Schmorl's nodes. And according to the autoimmune involvement theory, they tell us that intervertebral discs are the largest avascular structure in the body. So intervertebral discs are avascular. So therefore, parts of the body outside of the intervertebral disc itself never have any contact or any introduction to the precise molecular structure of the nucleus pulposus. And therefore, this nucleus pulposus material can be recognized as foreign matter when met by a well-vascularized source, such as the adjacent vertebral body, which, as we said, is highly vascularized and active hematopoietic tissue. So when the nucleus pulposus herniates beyond the cortical bone of the vertebral end plate here and up into the trabecular bone of the vertebral body, that stimulates an immune reaction with edema, influx of cytokines, and resulting pain. And this is what's going to cause the examinee to report pain in the exact region of the Schmorl's nodes. And this particular theory of autoimmune involvement in symptomatic conversion of Schmorl's nodes is supported by some MRI studies. We're going to go over a couple of MRI pictures here, which reveal that asymptomatic Schmorl's nodes are seen as low-intensity lesions on both T1 and T2 weighted MRI. So here's a T1 image, here's a T2 image, and notice that these Schmorl's nodes here both appear as dark, low-intensity lesions compared to this white, high-intensity signal from the cerebrospinal fluid here. These appear as low-intensity dark lesions on both T1 and T2 weighted MRI. On the other hand, symptomatic Schmorl's nodes are seen also as low-intensity lesions on T1 weighted MRI, but are seen as high-intensity lesions on T2 weighted MRI. And this conversion from low signal intensity to high signal intensity is most likely due to the presence of inflammation. So here on the left we have a T1 weighted image, on the right we have a T2 weighted image. And notice here up and around the region of T12L1 we have a Schmorl's node here which appears on T1 as a dark low intensity lesion in contrast to the high intensity lesion seen here on T2. And you can see this high intensity zone, HIZ, high intensity zone, right here on the anterior superior aspect of the vertebral body. And this is due to the presence of inflammation here in the case of a symptomatic Schmorl's node. And in this particular study, they investigated 16 Schmorl's node cases, of which 11 of the patients were asymptomatic. In other words, they had Schmorl's nodes found incidentally on diagnostic imaging studies, but denied back pain symptoms, and 5 cases which were reportedly symptomatic. Of the asymptomatic cases, every single one of them had a low-intensity lesion on both T1 and T2, and in the symptomatic cases, every single one had a high-intensity lesion on T2 weighted imaging. So MRI appears to be particularly sensitive to differentiating between symptomatic versus asymptomatic Schmorl's nodes, and this may be a diagnostic tool that you may employ in those cases where your examinee complains of back pain symptoms and also has the presence of Schmorl's nodes on diagnostic studies. MRI studies can help differentiate between the cause of pain in those particular cases where the examinee does present with Schmorl's nodes, but for those cases wherein it's unclear as to whether or not the Schmorl's node itself is the cause of pain, or whether it's simply an asymptomatic and incidental finding on diagnostic studies. Okay, so those are some of the postulated causes of Schmorl's nodes. The most likely cause is a cause that's much simpler and much easier to understand, and it has to do with what's referred to as the axial load model. And this is probably going to be the mechanism of injury and the cause of Schmorl's nodes most likely operative in the examinees that you have a chance to evaluate in the workers' compensation system. So let's talk a little bit about the axial load model of the development of Schmorl's nodes. In a 2010 study by Dar attempted to determine where in the spine are Schmorl's nodes most likely to develop, and he investigated some of the possible causes of the development of these Schmorl's nodes, and they found that Schmorl's nodes had their greatest distribution in the thoracolumbar portion of the spine, particularly at T11, T12, L1, and L2, with diminishing frequency of Schmorl's nodes both above those levels and below those levels. And they found that these particular levels were most likely susceptible to high axial forces. So Schmorl's nodes found in other parts of the spine, such as the cervical spine, such as the upper thoracic spine, such as the lower lumbar spine, may not be due to axial load trauma, but may be due to some of the other causes that we previously discussed. But for those Schmorl's nodes found in the thoracolumbar region, those are the Schmorl's nodes most likely to be due to axial loading, and these are most likely going to be the types of Schmorl nodes and the types of mechanisms of injury that you're going to encounter with your examinees in the workers' compensation system. So the study was entitled Schmorl's Node Distribution in the Human Spine and Its Possible Etiology. And Dar explained that because of humans' erect posture and because of their bipedal locomotion, humans must accommodate increased axial forces in addition to balancing the need for spinal mobility and spinal stability. And where in the spine are axial forces the greatest? And where in the spine is the need for spinal mobility and simultaneous spinal stability the greatest? This is greatest in the thoracolumbar region of the spine. So the conclusion was that the thoracolumbar spine may accumulate microtraumas that can, over time, lead to the formation of Schmorl's nodes in the general population. And Dar related this high axial loading forces and these high mobilization and stabilization forces in the thoracolumbar region of the spine. He explained that by referencing the alignment and the orientation of the articular facets of the thoracic spine and then of the lumbar spine. And remember, in the thoracic spine, the articular facets are oriented in the coronal plane. They're oriented in the coronal plane, whereas in the lumbar spine, the facets are oriented in the sagittal plane. So at the thoracolumbar region of the spine, there's a transition zone wherein the articular facets move from coronal to sagittal. And because of this differential orientation of the articular facets, this is an area of the spine subject to high mechanical and functional forces. And the problem is compounded in those cases where articular tropism or asymmetry of the spinal facets is encountered, where one spinal facet is oriented in a different plane compared to the opposite spinal facet. So you might have one articular facet on the inferior articular vertebrae, interior articular facet that's oriented coronally, whereas the other articular facet may be oriented more sagittally, or perhaps in some orientation midway between coronal and sagittal, or in some orientation where there's a differential orientation of the articular facets. So the conclusion of the study was that asymmetry of spinal facets is marked at the T11 to T12 levels of the spine, and the great incidence of Schmorl's nodes reported in the thoracolumbar transitional region is significantly influenced by the unique mechanical characteristics of the region. Mechanical characteristics meaning high axial load forces being transmitted through the thoracolumbar portion of the spine, high mobility demands, high stability demands. These are the mechanical characteristics of the region. And also the anatomic characteristics due to the transitional zone and the transition of the articular facets from coronal to sagittal, or to some midpoints even in between in the case of articular tropism, which demonstrates or which predisposes this area of the spine to increased susceptibility to both axial and twisting forces. And these particular features of the thoracolumbar area predispose the thoracolumbar area to the development of Schmorl's nodes. So when you encounter an examinee who has Schmorl's nodes on diagnostic imaging studies and who complains of back pain and who you determine is permanent and stationary at the time of your evaluation, you've got some work to do. You've got some work to do, and the work can be classified into the easy work and the difficult work. And the difficult work of dealing with an examinee who presents with Schmorl's nodes is going to be in coming up with your determinations on causation, AOE, COE, and on the apportionment approximate percentages. The easy work has to do with deciding on a permanent impairment rating for this particular examinee. And we'll go into that in just a minute because that's the easy part of this determination. The more difficult determinations have to do with causation. So for example, some things that you're going to have to answer to yourself and to the parties is, did the industrial injury cause the Schmorl's node? And this is most likely, if the industrial injury is a suspected cause of Schmorl's node, it will be because the mechanism of injury involved axial loading of the spine, either from some type of a trauma or some type of a fall perhaps, wherein large axial forces were encountered by the spine. Did the industrial injury exacerbate or aggravate a pre-existing and probably asymptomatic Schmorl's node? Are the symptoms and activity limitations that the examinee is currently reporting, are those due to the Schmorl's node, or are those due to other factors in the case of an asymptomatic Schmorl's node? And this is not a complete list of the things that you're going to have to consider when it comes to providing your causation determination. What about examinees who are permanent and stationary and who have a permanent impairment rating for some loss of function of the spine? Your apportionment determination is going to have to tell the parties what percent of the permanent impairment is due to the industrial injury, and what percent of the permanent impairment is due to other factors such as a Schmorl's node. So some of the things that you're going to have to answer include, is the current impairment caused by the Schmorl's node, or is it caused by other factors such as the industrial injury? In other words, is the Schmorl's node contributing to the permanent impairment? If so, what percentage of the current impairment, whether that be a low percentage, a medium percentage, a high percentage, is caused by the Schmorl's node, and what percentage is caused by the industrial injury? So you may determine that the Schmorl's node is not contributing at all, 0% to the current impairment, and you may determine at the other end of the spectrum that 100% of the impairment is due entirely to the Schmorl's node, and 0% is due to the industrial injury. And a lot of this determination on the apportionment approximate percentages, a lot of that is going to have to do with the mechanism of injury. If you can elaborate or determine that the mechanism of injury involved a severe mechanism of injury with severe loading, severe axial loading on the spine, it may be your determination that the industrial injury caused the Schmorl's node, and therefore 100% of the permanent impairment is due to the industrial injury. Or on the other end of the spectrum, it may be your determination that because there were no high axial load forces described in the mechanism of injury, and there were no high mobility or torsional stress forces on the spine in the mechanism of injury, that you may determine that the industrial injury is responsible for a very, very low percentage of the permanent impairment, whereas the majority of the permanent impairment is due to a pre-existing symptomatic Schmorl's node. Okay, and this is not a complete list, and this is where your medical decision making, of course, must be supported by substantial medical evidence, and this is where it gets very, very difficult. And I'll just leave this discussion at that. But for now, let's talk about some of the different permanent impairment options that you have available in providing for an impairment rating for examinees who have persisting back pain symptoms, who have limitations to activities of daily living, due at least in some part to a Schmorl's node in the thoracolumbar spine. Okay, so let's talk about different permanent impairment options. One option that you have for rating permanent impairment in examinees who have a symptomatic Schmorl's node, or for whom you believe that the Schmorl's node is contributing to their permanent impairment, is the DRE lumbar spine category 4 under the DRE method. Now, in order to provide a permanent impairment rating under the DRE 4 category, you need to obtain flexion and extension radiographs and do an analysis of motion segment integrity. For those examinees who demonstrate a loss of motion segment integrity, and in this case, you're probably most likely going to find a loss of intersegmental motion versus an excess of intersegmental motion. So for those examinees who have complete or near complete loss of motion of this particular motion segment that involves a Schmorl's node, you can provide for 20 to 23% whole person impairment for each level of the spine that demonstrates a loss of motion segment integrity. Now, for those cases where the Schmorl's node is located in the thoracolumbar spine, it's sometimes difficult to get good flexion extension radiographs, particularly of the lower portion of the thoracic spine. I myself am often not able to obtain good clear images upon which I can make the measurements to ascertain motion segment integrity of these lower thoracic segments. But if you can provide for a substantial permanent impairment rating for what is actually a substantial loss of function of the spine if that segment of the spine shows loss or near complete or near complete loss of motion at this particular motion segment. But I caution you on this method in that the only caveat is it's sometimes difficult to do flexion and extension radiographs in this particular section of the spine. The lumbar spine is very easy. The thoracic spine is very easy, at least in the upper thoracic section, where the lung fields clear out and allow clear visualization of the thoracic vertebrae, whereas in the lower thoracic spine, the individual vertebrae are sometimes difficult to identify and measure. Okay, so the DRE Category 4 provides you one option for providing for permanent impairment for these examinees. The other options are going to be presented to you, are going to be available to you through the range of motion method of assessing permanent impairment of the spine. So in those cases where you use the range of motion method, remember that the range of motion method for providing for permanent impairment involves three considerations. There's a specific spine disorder, there's a spinal diagnosis that goes along with the rating. Two is your findings on range of motion testing. So in these examinees, they will have loss of thoracic spine range of motion and or loss of lumbar spine range of motion. That'll be your second consideration to go into your range of motion impairment rating. And then the third consideration is whether or not the examinee has any neurologic deficits or pain. Pain would be a sensory deficit. So if the examinee has either sensory or motor deficits due to nerve root involvement, that would be your third consideration that would go into the formulation of your permanent impairment rating under the range of motion method. So what we're going to see is that the specific spine disorder, consideration number one, okay, consideration number one can vary, and you can provide for several different types of diagnosis or specific spine disorder diagnoses, whereas your range of motion testing and your neurologic disorder findings would be constant and independent of which of the specific spine disorders you ascribe or assign to your examinee. So let's take a look at some of the different specific spine disorder diagnoses that could apply to these examinees. So one option that you would have available to you in using the range of motion method for providing for permanent impairment rating out of table 15.7 would have to do with fractures. Fractures. You can describe a Schmorl's node as a compression fracture of one vertebral body. And this diagram here shows, this MRI image, shows a Schmorl's node is a fracture through the end plate and into the body of the vertebra. Now typically these Schmorl's nodes are not going to cause any loss of height of the vertebral body, so most likely would fit into the category of 0 to 25% compression of one vertebral body. You could say by analogy that this Schmorl's nodes penetrates the vertebral body by as much as 25%, and this particular classification would apply. If not under the strict application of the AMA guides, then certainly by analogy, this is one rating method that would apply. So for the lumbar spine, this would qualify for 5% whole person impairment for each level of the spine involved with a 0 to 25% compression fracture of the vertebral body. Next, you may decide that the specific spine disorder that most closely applies to your particular examinee is under category 2 of table 15-7. And this category provides for permanent impairment ratings due to intervertebral disc or other soft tissue lesions. So this exactly applies to Schmorl's nodes because of the involvement of the intervertebral disc herniating through the vertebral end plate. And in this particular example, most of your examinees are going to be unoperated on, so they'll fall under category A, B, or C. each of which provides for 0, 5, or 7% whole person impairment rating. And a category C would be an examinee who is unoperated on, who's stable, but who has medically documented injury with pain and rigidity associated with moderate to severe degenerative changes on diagnostic imaging tests, including a herniated nucleus pulposus with or without radiculopathy. And isn't this amazing? This herniated nucleus pulposus, typically we would think as involving a horizontal herniation into either the spinal canal or to the neuroforamen. But also with a Schmorl's node, we have a vertical herniation of the nucleus pulposus, either superiorly or inferiorly. And so this particular description applies exactly to Schmorl's nodes, even under the strict application of the AMA guides. And this in and of itself, the specific spine disorder, provides for 7% whole person impairment, and when added to the impairment rating due to abnormal motion or loss of range of motion, and then further when added to the impairment rating due to any neurologic deficits associated with the condition, this can ramp up to quite a high permanent impairment rating, which is appropriate because a Schmorl's node, a symptomatic Schmorl's node, represents a significant loss of function of the spine. And then finally, another option for you using the range of motion method is found in category 3 of table 15.7. And this is more of an analogy than it would be an impairment rating under the strict interpretation of the AMA guides. But you may provide an impairment rating by analogy to spondylolysis and spondylolisthesis. And why is that? How does a rating by analogy to spondylolysis relate to a Schmorl's node? Well, a spondylolysis, like a Schmorl's node, involves a fracture of the vertebra. Now, they involve different portions of the vertebra. As spondylolysis involves a fracture of the posterior elements of the vertebra itself, whereas a Schmorl's node involves a fracture of the body of the vertebra. Both involve fractures, so they have this anatomic injury in common. And because they involve similar mechanism of injury, because a spondylolysis can be traced back to early childhood, as can Schmorl's nodes. In the case of an embryogenic cause for Schmorl's node, or in the case of a Sherman's disease cause of a Schmorl's node, can be traced back to childhood, as can a spondylolysis. You know, most spondylolysis studies indicate that a spondylolysis is a stress fracture of the pars interarticularis, most commonly suffered between 5 and 7 or 6 and 8 years of age, as children go through their first periods of extensive weight bearing sitting as they enter elementary school. So spondylolysis can be traced back into childhood, similarly as can Schmorl's nodes, and they both involve fractures of the vertebrae. So you may decide that an analogy to spondylolysis and or spondylolisthesis is the most accurate description of your examinee's condition related to Schmorl's node. So doctors, I hope this helps you. Isn't this a fascinating discussion? You know, you're going to encounter examinees who present to you with many types of anomalies of the spine. Many findings of the spine are going to confront you as you examine spine injury cases. And those anomalies include all different types of findings, such as lumbosacral transitional vertebra, spina bifida, block vertebra, what else? Transitional vertebra, block vertebra, spina bifida. You're going to encounter examinees who have these conditions, and these conditions are known causes of back pain. Well, similarly, you're going to encounter examinees who have Schmorl's nodes on their diagnostic study imaging findings. And it's going to be your job, and it's going to involve your medical decision making to determine what is the significance of this Schmorl's node in terms of the overall opinions and conclusions that you're going to offer in your report. And the purpose of today's discussion is to give you some background as to the many different causes, both industrial and non-industrial, of Schmorl's nodes. Now, in those cases where you conclude that the examinee has a pre-existing asymptomatic Schmorl's node, that previously asymptomatic condition is unlike or is like any other pre-existing asymptomatic condition that may contribute to permanent impairment and may also be involved with your apportionment determination in apportioning out the percentage of the permanent impairment due to the lighting up and the aggravation of the pre-existing asymptomatic condition. Or it may be your opinion that the industrial injury actually caused the vertebral end plate fracture and herniation of the nucleus pulposus into the adjacent vertebral body. And it may be your opinion that this was the direct result of the industrial injury, for which 100% of the permanent impairment is due to the industrial injury and 0% is due to other factors. So Schmorl's nodes are going to present to you along the entire spectrum of the range of your opinions and conclusions, and it's your medical decision making that makes it, that makes the finding, that makes the determination. And it's your support for your opinion and your support for your inclusion that will make your opinion and conclusion and your determination stick and be the determination upon which the case and the disputed issues are resolved. So I want to thank you for taking the time to join me on today's discussion. I look forward to being with you on our very next discussion as well. And for now, this is Dr. Perry Carpenter. I want to thank you for your commitment to excellence, and I'm wishing you best of success in your career as a qualified medical evaluator.